I extend a warm welcome to all of you for this 19th edition of Clinical Neurology Forum, where we discuss interesting cases presented from various institutions and various cities. And we have Professor Velusamy, Professor and Head of the Department of Neurology at Keele Park Medical College, as our chairman today. And as all of you know, Velu has been a former professor at Stanley Medical College, has now moved over to Keele Park Medical College. He has a number of presentations and publications to his credit. He is a pediatrician cum neurologist, and I welcome Professor Velu. Professor Velu, you can take over. We have as moderator from the SRM Institute of Neurology, we have Professor Arunan, who is the head of the department and professor of neurology at SRM Medical College, Kattangulattur, and he will be the moderator for the case which is going to be presented by Dr. Aruna. We have Dr. Shankar Balakrishnan, neurologist of repute from MEOT, who is not only a neurologist, he is also a stroke interventionist and also a movement disorders man. So he will be presenting a case from MEOT, his own case. I hand over to Professor Velu, Chairman, Professor Velusamy, to conduct the proceedings henceforth. Velu, you conduct from now onwards. Thank you.
Yes, sir. Good morning, everyone. At the outset, I would like to thank Professor VN sir for inviting me and for giving me this opportunity. Welcome you all for this 19th Clinical Neurology Forum. I welcome Professor Arunan. He is head of the Department of Neurology, SRM Medical College. The first case is by Dr. Shankar Balakrishnan from MEOT Hospital. I request Dr. Shankar Balakrishnan to present his case. It's a case of myelopathy with his institute experience on epidural cord stimulation in improving the locomotor disability. I request Dr. Shankar Balakrishnan to present his case.
Thank you, sir. Thank you.
The screen is visible, sir.
Yeah. So I think my screen is visible now.
Yes, sir. Yes, it's visible, sir.
I thank Professor VN and my teachers, everyone for this nice opportunity. And it is after a long interval, I'm presenting a clinical case, and I should thank my teacher.
Login panla. Morning. Login. Your hand reflexes.
Hello.
Arnan, mute panninga Arnan. You continue, Shankar.
Thank you, sir. Thank you. Like I'm proud to be an MAN student because I learned neurology. After MD Pediatrics, when I took neurology, I was scared that I could learn neurology, but keeping the eyes and ears open in the corridor of MIN, the neurology itself, it will flow inside us. Just we need to keep open. That's how I started with the neurology. And didn't stop with neurology. I got a chance to learn intervention neuroradiology from Switzerland. And with all motivations, we are able to do deep brain stimulation for and the movement disorder. Subunit is running in MEOT, and with all the teacher supports, I'm able to do small things. And what is new is every year we develop something new in the institute. And what we are working on the research side is epidural electrical stimulation for patients with spinal cord injury and spinal cord disorders. So the paralyzed individual, there's FDA has approved pain modulation, but something like the new research is using the same methods, how to make them walk also. So this is what the research part that we're doing. And today's case is like, since it's related to the spine, I'm going to present a young kid. So a young kid who's 5-year old. He's from Sudan. So Diol Domak, Diol Chol is his name. So he was a male child, third order by birth, born out of non-consanguineous marriage. All antenatal, perinatal, and birth events were normal, and his development was also normal until the age of 5 years. Everything was going smooth. All of a sudden, on 29th March 2022, he developed an acute onset of weakness of both the lower limbs, along with urinary continence and some sensory disturbances below the level of umbilicus. And then Sudan is such a country that the current civil war is going on. There's a lot of difficulty in moving to hospitals, and everything is compromised there. And when they were able to reach the hospital, and then they got admitted. But during the course, the weakness was slowly increasing, and then he became bedbound within a week. And the Sudan hospital did basic evaluations, like MRI spine was done, and they thought some demyelination in the spinal cord, started on steroids. And since there is no significant improvement, he was referred to India for the further management. So the presenting history was apparently normal until March 2022. So he was the first symptoms is the weakness of both the lower limb, which is acute onset, and like manifested in the form of difficulty in getting up from lying posture, inability to stand or hold sandals. He went to bed normally the previous night, and when he woke up, he couldn't move his leg. But on the bed, he was able to rise. Like on the gravity eliminated movements, he was able to do, as what the parents said. And he told that he felt some numbness below the lower abdomen and lower trunk. And as the day progressed, he told that the parent noticed that he's voiding urine without his control, dribbling of urine. So when the examiner was abdomen was distended, so taken to a nearest hospital and catheterized, they were able to let out 500 ml of urine. But fecal incontinence was not there. But there's a history the parent gave. And negative history says on that day there was no altered sensorium or loss of consciousness or convulsions. And any history when we provoked to involve the cranial nerve involvement was normal. When we provoked a few histories related to the etiology, like evening rise of temperatures or evidence for tuberculosis or contact with tuberculosis, was nothing. And there's no significant trauma or injury. There's no dog bite or vaccination around that March. And as such, there's no spinal procedures or like lumbar punctures or intrathecal was done. Like since birth, there was no intervention done on the spine. And there was no radicular pain, and there was no photosensitivity, no significant arthralgia, rashes until 5 years of age. There's no thyroid illness. And for all patients traveling from abroad, including the parent, we always do some basic blood investigations, and then parent is also negative for HIV. And when it's like on arrival, usually the residents will ask for complications like chills, rigors, any evidence for bed sores, with a breathlessness, and also for DVT prophylaxis, we provoke some histories. And when we provoked the treatment details, we didn't come up with any papers or images, but whatever they sent through the agents was a single paper in which it is written as spinal cord demyelination. And like steroids were started, but there was a minimal improvement, but then there's no significant improvement was there. So he was referred to here. And in the past, there was no history significant. Similar episode never happened until 5 years of age. There was no major medical or surgical, and no systemic comorbidities. Development-wise,
Shankar, 1 minute. I
Yes, sir.
take it that he had no visual symptoms,
no, sir, no visual symptoms, no
no
visual.
loss of vision or burning. Okay.
No, sir, no, sir,
Thanks.
nothing. Yes, sir. I think I mentioned cranial nerve involvement was negative. Development and cognition wise is normal. He's going to a school nearby, and when compared with the peer age groups, he's able to do all the things. He tend to have a little bit of nail biting behavior, but he's definitely a normal kid for that age. And in personal history, there's no history of allergy, no systemic comorbidities.
Shankar, you have written his speech was not age appropriate. What do you mean by that?
He was a little bit not talkative. Sir. He's not talkative. So we suspected some autism behavior. So when our psychologist interviewed her, she noticed that speech was not age appropriate when compared to the kids. So he was able to talk normally, but the fluency and articulations was little bit he find difficult to communicate. Where one or two words he speaks. That was what the psychologist told.
But writing,
And
learning,
yeah, that all is normal. Normal. Maybe
okay.
language barrier or not. The psychologist that noticed that point, and she conveyed us that his language was not appropriate. And because of the COVID and the current civil war situations, child are not able to go to the schools. That could be also be a reason for language not appropriate for their age. So when on arrival, the child reached around midnight next day morning. When we saw the child, he was lying on the couch. He was catheterized and parent was there. And general examination didn't contribute much. We especially focused on the back. There was no hyphosis, spinal deformity. Skin was normal, no epidural swelling, no gibbous. And the system examination was normal. And we looked for lymphadenopathy, it was normal. And CNS examinations, when we examined the first, the child was able to communicate. So we thought the speech was normal. And child was able to follow simple instructions that we gave, but language barriers, child find it difficult for initial assessment. Cranial nerve examination, his vision was normal, and there were a lot of limitation in examination of the cranial nerves, but in gross, whatever examination that we could do, so didn't contribute much on the cranial nerves. So a detailed ophthalmic evaluation was also done, and pediatrician also were like involved in assessing the nutrition and anthropometry. So he was age appropriate, and for there's no muscle wasting, fasciculations or asymmetry noted in him. Tone, lower limb was hypotonic, and the reflexes were absent in both the lower limbs, and even I think the superficial reflex was there. So superficial reflex, plantar was mute, cremasteric absent, and anal reflex were absent. And upper limb was completely normal on examination. Lower limb around the hip, it was 2/5. And so this is a typographical. The anal tone little was not, it is patulous, and anal tone was reduced. Knee is around 2.5. And ankle, is there was an asymmetry. Right side he could move a little bit. Pitch of movement was there in ankle, but left side it is 0/5. Sensory examination.
What was the tone? What was the tone, Shankar?
Hypotonia, sir. Hypotonia, lower limb hypotonia.
Okay, okay, thank you.
And sensory examination was very difficult. He didn't give a proper. It was when there was multiple variations, but there was some deficits was there, and which is below like around snaps on the, and it was varying, and they was treated with steroids. So sensory we couldn't control, but definitely there was reduced sensory system was affected, and it was a very limited examination. To summarize, a 5-year-old kid from Sudan was normal until the age of 5 years, developed an acute onset of weakness involving both the lower limbs, urinary continence, and sensory disturbance, and which progressed and then minimally improved with steroids, and imaging done there shows some demyelination. And since there was only a minimal improvement, he was referred to India for the further management. And when we examined what we could localize it, it's with the involvement of bladder and though the lower limbs, we thought it is localized to the spinal cord. And since there was a hypotonia, we thought it's an acute spinal shock. And level is definitely, he couldn't convey any sensory level or a band-like sensation over the trunk. But with whatever sensory information that he could tell, it's those below the umbilicus, and motor power and all includes like it it should be above the coraconus. And since the anal tone was reduced and premenstrual reflexes are all reduced, we thought it's somewhere close to T12 region, and we started evaluating him. Initially, we thought, since it was in the mind that when he referred us to demyelinations, the moment he came, we started evaluating parallelly with the imaging all the blood works also, and like the prominent things that we struck is to rule out demyelination. So we were intensely searching for aquaporin and NMO, MOG. Some of them are not mentioned, but including MOG was also done, so including anti-neuronal, all the profiles, even vasculitic profile, detailed vasculitic profile, a rheumatologist was involved. Infectious conditions, even think of brucellosis, and so was also done, but nothing was contributing except elevated cells and proteins. It was not there. And once we do the like imaging was parallelly done, so all these blood investigations were sent, and when we saw the scans, so our perspective completely changed. So what we could see is this cord edema, significant cord edema in T1 and then T2. But when we give a contrast, when we see the lesion itself, strike that it is something other than a demyelination. So the intense with the intense contrast enhancement, and the pattern was patchy with disappropriate edematous cord. What we thought is it could be some a tumor other than like a demyelination. So the entire axis also we have done, the entire neuron axis other than this lesion was normal. So we had a detailed discussion with the surgeons also. We have a neuroscience.
Shankar,
course.
what is that nodularity? You see some nodules there, about
Yes.
4 nodules in the cord.
Yes, sir. So that picked up, that raised some nodular lesions in the cord. So that is what made us to think away from demyelination, that nodular structures. So immediately we switched to we planned for a biopsy. So the surgeons were kind enough to do a laminotomy to expose. We can see an edematous and erythematous spinal cord, and we give the fluorescent injection to differentiate lesions, and we could see these nodular lesions there. And surgeons took a biopsies from those lesions, and we sent it, and this is what we got it in the biopsy. So it is a chronic granulomatous, and what we are seeing in the middle is the egg, and surrounded by inflammatory cells. So immediately, but for the first pathologist in the initial process told some chronic granulomatous, but soon we searched for it, and then they found in the hematoxylation that it is an trophozoite schistosomiasis. So the modified Z-lending stain shows that the pink colors is the wall of the like the egg, and there was the intense inflammatory reactions. So they told it is schistosomiasis. So we started him on praziquantel and steroids. Just within the first week video, the second week and third week with intense neuro rehabilitation, he recovered a lot. So when he went home, he was completely independent and he was able to do all his activities. So it's what I wanted to insist. It's a team approach of neurologists, neurosurgeons, neuroimaging specialists, and finally the rehabilitation specialists. So they all worked together. So with the rehabilitation, the recovery was very fast, and then we didn't know like there is a lot exist in rehabilitating such kids who will not cooperate for the regular exercise. It was entirely based out of play therapy. And so
Shankar, when you plan the surgery,
yes, sir.
this is myelopathy. It's a parenchymal lesion of the cord.
Yes, sir. Yes, sir.
And did the surgeon feel confident? Why did they not go for an total removal.
So surgeons, when they saw the nodularity, what they told is they told for biopsy of the lesion. So they didn't want to remove in toto. So went with a plan of biopsy. So they minimally opened the cord and then they took, because until the histopathology, we were all thinking something like a tumor or something. So they wanted to do the biopsy and it sent it. And when they told it is a chronic granulomatous disease and not a tumor, the surgeon didn't want her to remove everything out. So frozen section report was chronic granulomatous disease. Since it's a medical conditions, they didn't do any further things. I think.
Yeah, but the differential diagnosis before the biopsy was included a tumor and a space occupying lesion, wasn't it?
Yes, yes, sir. So in the discussion, they told they will do a frozen section and send to it. If there is any evidence for any malignant cells, I think they wanted to remove in toto. And since frozen section was pointing towards, they didn't wanted to remove, and then they come out.
Okay, thank you.
The cystosomiasis was thought of before surgery because patient is from Sudan.
Yes.
We
So-
thought of that.
Yes, sir. Actually, this is the third case from Sudan with cystosomiasis of the spinal cord over the past 5 years. This is the third case.
Will it present acutely? Will it present acutely, or what is the presentation of?
Usually, it doesn't present acutely. I think it is the edema or the inflammatory reaction that happened around the spinal cord could be the cause for an acute presentation. The
Does
other
it involve the CNS at all? CNS, particularly the spinal cord?
Yes, sir. The previous two cases, the first case was very difficult for us to diagnose. It was sent to Nimans, and then from the Nimans only we could get. But after that, the radiologist got alerted. If any Sudan patients comes with such cord edema and thing, they search for this nodular, and then they themselves raise the suspicion of cystosomiasis.
Oh, how do they get infected?
It is vascular, so through the vascular only they get inside. The eggs gets inside through the vascular.
The mode of infections, whether it's
Cystosomia is the three species: Hematobium, Masoni, and this is one is through the Hematobium is in the bladder only, confined to the bladder. In the bladder, they poach and then form a granulomatous lesion in the bladder wall. Hematobium. Mansoni goes everywhere inside the body. So it's
Isn't it through the skin
enters-
that it gets infected?
It penetrates through the skin and then goes to the intestine. From there, go to the liver, and then it spreads through the hematogenous to every part in the body.
Oh. And this boy did not have manifestations of other systemic involvement.
No, sir. No other systemic involvement was there. Even the stool also is examined, but there was no ova, nothing in the stool. So retrospectively, we looked for the ova stools also, but it was not there. And detailed after also done, liver scans, everything was done, but nothing we would find anywhere else.
How long will you continue praziquantel?
6 weeks.
so that nodular thing is specific for cystosomiasis, or is it a common finding in cystosomiasis, nodular enhancement?
The nodular enhancement is commonly seen in cystosomiasis, especially when they come from endemic region like mid-African regions. When nodularity is seen, it raises suspicion of cystosomiasis. So other parasitic infections we have not come across much, even from the mid African countries and other part of the world. But cystosomiasis tends to reach the spinal cord. We don't know like why the why it's common in the spinal cord, but all the three cases are cystosomiasis.
Very interesting, very interesting. Comments from others?
Hello, sir. Vijay.
Yes, sir, please.
Maybe you can call Shankar stomiasis because previously I remember one case when I was in Nimmans, Professor Shankar, the late Professor Shankar,
Yes.
showed us a case of brain schistosomiasis in a patient with HIV. In spite of the various differential diagnosis, everything was wrong. And he finally, I still vividly remember, he asked the radiology PG to tell what it is, whether it is inflammatory or infective. Then the PG told it's definitely inflammatory and not infective based on our findings. Then he cut open the brain and he showed us cystosoma, trophozoites, streaming trophozoites in the brainstem. It was in the brainstem.
This
That's
is
the
an
one
Indian
case I
patient,
remember. Sir, HIV, yes, sir. Yes, sir.
but an Indian patient.
Indian HIV patient, sir.
And what was the pathogenesis in? How did he get infected?
So I don't remember all that. This was when I was doing my post graduation
Okay.
20
Okay.
years back. There is a brain cutting
Fine,
session
fine.
which he regularly does on Fridays. And one of the brain cutting sessions, he showed that trophozoites were streaming all over the white matter.
Thank you. Thank you.
Maybe we can call it Shankarstomiasis.
Yeah. Any other inputs, particularly pediatrics, because it's probably found more in children?
I think it's not so. It's not common in children. I think it's patient is from the endemic area. That is the thing.
Yeah, I'm Dr. Megan Dan, sir.
Yes, sir. Welcome.
This is a very interesting case because I remember when we were studying undergraduate, probably Chatterjee parasitology.
Yes, sir.
We used to read about the schistosomiasis. Of course, when I was in the Department of Pediatrics under Professor K.A.K., he used to ask about the schistosomiasis as a differential diagnosis only. But this Occam's razor has cut that, and we don't call it because we don't see. But we used to get case reports from Calcutta at that time. One or two cases probably they are presented in Indian pediatrics. After that, probably we have never seen CNS either in spinal cord or the brain. Never, we have never seen, and this is something which we should think of. How did this boy get it? I'm sorry, I got it a little late.
Yes, sir.
How did this boy get the infection? Like, what do you think the root he would have got?
So these in Africa, water is the source. Most commonly, it's a water source. Which
Oh, he was in Africa.
yes, sir. He's from Africa. Sudan.
Oh, sorry.
Yes. So it is. I went, and when we saw the first case, we did some literature how they get it in Africa. It's a water source. So it's a Nile River. Nile is a river where every African kid, until they reach the adolescent, they has to cross the Nile from one age to the other. So every kid in Africa will do that, crossing the Nile, swimming training from very early childhood. So it's a waterborne, probably. So that is why I say so. In Sudan, both the Niles, the White Nile and the Blue Nile, joins together at Sudan. So I think it is waterborne most of the time.
Shankar, were
Yes, sir.
all your three cases, the presentations, was it of an acute myelopathy, acute myelitis? This is almost a transverse myelitis-like picture.
Yes, sir. Yes, sir.
Were
Initially,
all your other two cases also, were it acute myelitis-like picture?
no, sir. The other two presented with severe pain and then a weakness of lower limbs, and pain was so severe, sir. They presented with pain and some weakness.
That was subacute to chronic.
Subacute to chronic, but not anything acute.
This is almost an acute transverse myelitis-like
Yes,
picture.
sir. It is a wake-up event. So
Yeah, that's right.
Yes, sir. And when they sent the report also, that's why they in Sudan also it's a wake-up event. They thought it is a demyelination, tracking transverse myelitis. So the picture was a little confusing, but the radiologist got alerted now after the third case. So in the discussion, they showed the nodularity, and then
The nodularity was seen in 1.5 Tesla or 3 Tesla?
it is 3 Tesla. It is 3 Tesla. So all the international patients, they go for 3 Tesla only.
Nodularity is only enhancement, no? It's contrast enhancement is a nodularity.
Yes, contrast enhancements was nodular.
Sir, if I may add something
Is there
more.
any-
Yes, please, Jain, sir.
One more, during the COVID times, we have a lot of work, about ivermectin being given. Then I once asked my pulmonologist, in spite of so many negative papers, why are you still giving ivermectin? Single shot. They used to give. I think it was prescribed all over by most of the infectious disease specialists, including in Chennai. And
At
that's what
onset,
we copied.
at onset
Yes,
of COVID, it was the prescription.
Yes, sir. Yes, sir. Then I asked them why you are still giving it. Then the answer given was, if there is schistosomiasis, to prevent it
Sorry?
from flaring up. The answer given was, if there had been occult schistosomiasis, to prevent it from flaring. That was the
Oh.
answer they gave. That was the answer. I think it was given throughout, sir. And in one specific hospital, I don't want to mention the names, but leading people were giving it as a single dose.
Yeah, in many hospitals it was given. Yes.
Yes, sir.
I know that.
Yes, sir. Yes, sir.
So it was part of the treatment protocol itself.
Yes, sir.
That
And
was,
when
that
I
was
asked them
included.
specifically, they
Ivermectin was
told it
initially
to
excluded.
prevent-
Included.
Yeah, they told that it was to prevent flaring up of schistosomiasis, not for COVID. That's what they gave the answer.
Interesting name in India. Shankar, anything more you have to say on Schisto?
No, sir. It was an interesting case, though it is not.
Absolutely, yes.
Yes, and though it is not common in our part of the world, now every hospital is now getting patients from abroad. So I thought it is interesting, so I just presented. Like, presentation is one for about rarity and the teamwork. So I just wanted to.
Is there
What
any
other
predilections?
protozoal infections do you see? Because you get patients from international many countries.
Yes.
What other protozoal infections of the cod you get is cod or brain you get to see?
So mostly toxoplasma. So they present a lot of Africans as HIV positive with the toxoplasma. We come across a lot of cases of toxoplasma. We commonly see that. And apart from that, African MS is very aggressive, very aggressive multiple sclerosis types. So they go for EDSS score goes down, they become paralyzed by 25 years, they become completely bedbound. So that is again a common thing that if it is related to spine. Protozoal, I think schistosomia, toxoplasma, and nothing. So HIV is common, so we could all.
Not much of amoebic encephalitis.
No, sir. Amoebic we didn't come across because most only those who are stable enough to travel they reach here. The six
right.
may not reach here. So somebody
Toxoplasma of the cod.
Yeah, toxoplasma of the cod also we have seen, sir. HIV positive. He was working in Kenya, and then he with multiple lesions, multi-axial. Even the cod also.
What about cysticercosis involving the cod?
This
I
is
come across.
no, I have not come across the spine.
And is there any predilection of all the 3 cases, whether all the 3 cases involve the lower cod or lower thoracic?
Lower thoracic. All three lower thoracic.
So is there
Almost
any-
like mog-like presentation.
Mog.
Yes, sir. I don't know, it depends upon the vascularity because it's the basket of vessels at the coraconus. So that could also, sir. So it is a network. When you look at the angio architecture of the spinal cord, so the coraconus is the richest the network of blood vessels around that. When we do the angiogram, we see the completely kind of basket built with blood vessels around that region, a highly vascular and minute capillaries. So they tend to get deposited there.
The other 2 cases also were diagnosed by biopsy, is it?
Yes, sir. Other 2 also we did the biopsy, but they told chronic granulomatous disease for the first case. So we sent it to NIMHANS, and then it came out to be schistosomiasis. So then the pathologists and radiologists, they started doing more, and then now it becomes easy for them to think and then suspect African nodular, and then they're searching for schistosomia.
And all three were treated with praziquantel and steroids.
Yes, sir. Praziquantel and steroids.
And all of them improved.
Yes, sir. All of them improved. So one patient, the first case, actually, the surgeon took a big chunk of the lesion. So that patient had some weakness was there, persistent
Residual deficit.
residual deficit was there. So others improved. Other two improved completely.
Velu, Shankar has some more to present, something
Yes,
else
sir.
also to present.
Yes, sir. You continue. Shankar, you can continue.
Thank you, sir. So I won't take much of time. So this is just to share our work, sir, our teamwork, something that we are doing. A small video clip. So the total duration of the clip is 10 minutes. This is.
You can take time. There is time. You can go ahead.
Thank you, sir.
You
Thank
have 20 minutes.
Yes, sir. Sir, epidural electrical stimulation was done for pain, but it is also now used to bring up locomotor recovery after spinal cord injury or any medical disorder, even multiple sclerosis. The basic concept is with the injury or the medical disease, when there is an injury to the spinal cord, the signals are not transmitted to the nerve roots. So, but when we see a trauma case, even there is a cutoff or a multiple sclerosis patch or an acute transverse myelitis. When radiologically we see disconnection, but there will be some residual connectivity will be still there. But those residual connectivity is not enough to transmit the signals to the lower limb. And when we look at spinal cords, we look for the myelomolecular changes in the cord. And we also do a tractography, whether there is any residual supraspinal connectivity is there or not. So the site of location, the time since injury, the severity of ASIA, the paraplegia, is not all has a role. Somebody who doesn't have an atrophic cord will not improve with epidural electrical stimulation. Somebody who have a lesion on chorda cones will not be a candidate for epidural electrical stimulation. Age is not a criteria. So what is important is the amount of the supraspinal connectivity and the location of the lesion. These two are very important. And when we look at the mechanism, how this epidural electrical stimulation works is, when we put a lead on the surface of the spinal cord, and when we stimulate it, the current doesn't penetrate the spinal cords. So what actually happens is, the current usually spread along the surface of the spinal cord and it reaches the roots. So when the current reaches the roots, the unmyelinated fibers, they pick up the current, and then the current travels via the roots through the dorsal horn. It enters the anterior horn cells. So it excites the anterior horn cells. This is the mechanism. So and when the anterior horn cells are excited, any residual connectivity, means any thinking, even a small signal that comes from the brain, it picks up and it brings on movement in the lower limbs and the upper limbs. So the conventional rehabilitation for paraplegia is gold standard. It's not like it's not useful. It is useful. It brings them alive. Simple thing like moving from wheelchair to bed, strengthening the upper limbs, or bringing out the hand functions, and passive movements, passive stretches to reduce the spasticity. All the conventional methods are adapted. But what is more important is, does it brings any change in their life? A lot of changes, but does it makes them to walk or any attempt to walk? Actually, paraplegic he himself will feel when his toe moves, he gets excited. Yes, he is able to move his toes. So that is the basic ethics. And when the signals is getting interrupted from above due to any reasons. So all these imaging methods like advanced MRI and everything helps. And when the board will discuss, and then we named it as STIMO. It's a stimulation movement overground. This is this is epidural electrical stimulation, or the circus to bring the movements, not only to reduce the pain or something, to bring movement in the lower limbs. What is more important in this is the placement of electrodes is done by the surgeon. Do a small laminotomy. So just a small hole so that the lead can go inside. The lead is very thin. It is like 0.5 millimeter thickness and about 2 inches length and 2.5 mm width. So it contains 3 columns of electrodes. The first will contain 5, and another, the second row contains 6 electrodes, and third row there will be another 5 electrodes. So it's called 5-6-5 system. So when we put these electrodes inside, and even intraoperatively also we do monitoring, put needles in the muscles, and when we stimulate the spinal cord, we pick up electrical activities. It means we are able to excite the spinal cords, and we pick, especially we look for the quadriceps, calf muscles, dorsiflexion tibialis anterior, and hamstrings. So all these muscles will throw signals all during. And for the next 2 months is EMG guided mapping. Mapping is the most difficult part to map the spinal cord. So we play with 3 parameters: the amplitude, the frequency, and the pulse width. So when we map the spinal cords, every patient will have their own unique combinations. So with this 5 systems, when we play with these 3 players, try to bring violational movements first. So initially, patients cannot think and move the legs, but the electrical stimulations will bring the movements of the legs. But when we try to tune them again and again and again, so over a period of time, the thinking process and the focus that they pay will bring about supraspinal connectivity strengthen. So it is also proven that the neural plasticity increases and the volume of tissue activated will also strengthen. And besides it, the currents that is the supraspinal connectivity, the DTI fibers are also like getting strengthened. And there is an radiologically also, and by imaging wise also, they were able to prove that this constant thinking and training brings improvement in them. And to make them walk takes around 1 year to 1.5 years, and still they will need some minimal support to walk. So this kid got an injury around D6, D7. He falls from a tree. He hailed from a small tiny island called Tuvalu. The total size of the country is 18 kilometers. It's just a strip of land in the middle of Pacific Ocean. So when it's not only take care of the motor activity, but it studies have shown it definitely like proven effect on the autonomic imbalance. Bladder symptoms will also improve. So studies are coming up, especially for autonomic, definitely like all the studies shows positive results. So for a paralyzed patient to move the leg itself is a big dream. And epidural electrical stimulations, what we started, is able to, this moment it's not stimulation. The current is on, but he's thinking and then he's trying to move the leg to kick it. And then the walking movements, initially they will need assistance. So some like our physio team will hold their legs and make the stepping movements. But over a period of time, when he think, he can step and then bring a forward movements. There are a lot of limitations with the current electrode. This electrode is for the pain, so the length is small and it is also not broader. But that's why we're not able to get a good truncal stimulation. So we can cover the cauda conus, but if we get a longer lead, it will give stimulation for the trunk also. So trunk we are strengthening with the conventional methods. But when you stimulate with the lower limbs, so over this guy he's from Atomic Power Station. He's able to walk on the parallel ball with the stimulation on. Like it's all like lab work only. We didn't let them to do any outside lab. We won't let them walk. It's under supervision and under safety precautions. They started moving and trying to walk on the parallel bar. So once they come to a stage, they were able to walk on the paddle, we discharge them, send them home. And at home, they will do their own practice and comes once in 3 months for fine tuning of their settings. And it is completely a team approach. The orthopedic spine team is strong here. They refer a lot of patients. And so the rehabilitation specialist, and we introduce a new terminology called neuromodulation specialist, who will spend around 3 to 4 hours with the patients in mapping the spinal cord. And once I entered and then retrospectively saw how a paraplegic, like how they are in India, is there more number of, and I got opportunity to visit centers like Indian Spine Injury Center, which is a completely no profit, no loss center who's helping paraplegics to do a lot of work. And slowly I got like introductions with the IIT professors who are working a lot on like standing wheelchairs. And there's one device called NeoMotion. Now the government is going to adapt. The NeoMotion is like a motorbike. There's no need for the patients to get down from the wheelchair to the motorbike. The bike attaches to the wheelchairs and then he can go around the here vicinity. So there is a lot of scopes and lots of research works and a lot of emotional, ethical, and treating patients with spinal cord disorders. So this guy, so he told he's never going to walk. That's what his first word when he came. Right? When we look at not only from the movement perspective, that spinal cord injury patients have got an entire life to go ahead with. And as a neurologist and to work in MIOT, I got an opportunity to work on this research area. So finally, whatever be the disease, to make them happy and to lead a normal life or near normal life is what would be the goal of our team. Thank you, sir.
Shankar, thank you for the presentation. When they improve, is there a differential improvement of distal and proximal muscles, or they uniformly improve?
It is targeted towards the movement, sir. It's stimulating the locomotor system. So it is not targeted on the muscle. The locomotor system is there in the spinal cord itself. And now the current concept is the locomotor system can function on its own. In animal studies, the locomotor system can function on its own without the control of the brain if we train them. So, but even then, the minimal supraspinal connectivity in human drives is necessary. That's how when they think, they can move the leg. So it is not focused on the muscle power or the muscle. When we switch off, it's completely 0/5. So it is bringing up locomotion, like how a newborn do a stepping reflex. So it is the locomotor system which causes the stepping reflex. So it is the local reflex to make them walk, to tune the local system to act independently with a minimal trigger from the brain.
See, we are stimulating the anterior horn cells. Am I right?
Yes, yes.
So
Sir.
how does it work on the locomotor system?
So the connections, when we stimulate the anterior horn cells, it's sensitized to fire the first signal. So through the intermotor neurons, whatever, like when we touch the fire, how we remove the hands. So the system acts within it. So the sensitized anterior horn cell will throw the signal to activate the local system, and then it brings out a stepping like movement or a walking like movement. So these are not like the real walking movements. So it is when we train them again and again and again, it becomes like a walking like movement or a cyclical movement. So that's why it is very difficult to walk like a normal. It is all how they walk is like a newborn, how they make the stepping reflex, and training them to make them walk.
So it would be a constant stimulation.
Yes.
And would you vary the intensity of the stimulus, that somebody has to monitor it throughout to see the modify the intensity of the stimulus that is being given?
Yes, sir. We create multiple programs. Like for cycling, one program will be there. For standing, there will be a program. For walking, there will be a program. And for constant, to bring out autonomic instability, bladder and bowel, that will be a baseline program. So only when the patient wants to walk, he will switch the program to walking mode. Or when he wants to do the cycle, he will switch to cycle mode. And most of baseline is to bring out the bladder control and for sexual functions and to get away with autonomic instability. The base currents is sufficient to keep the anterior horn cells sensitized. So monitoring during the stay in the 6 months, first we start with controlling the hemodynamic. Once we make the paraplegia stand, they will immediately go for an orthostatic hypotension. So we use the tilt table slowly and we give the constant stimulation. Within 7 days, the autonomic instability comes under control with epidural electrical stimulation.
How
Yeah.
long is hospitalization required?
So it depends upon patients to patients. Minimum, we recommend to 4 to 6 months of stay in the hospital.
Oh,
What's the cost?
So,
What's the cost?
yeah,
Cost?
so
depends on the
implant-
hospital.
the implant is around, so battery and the leads together will come around 12 lakh rupees. So with this new in-house rehabilitation, we are charging 2,500 rupees per day, including programming, modulation, occupational therapy, physiotherapy, even psychology, mapping, and robotic altogether is 2,500 rupees per day.
So battery-
Vijayan, are you there?
Yes, sir.
Vijayan? So
Yes,
some more armamentarium for you to work on. Some more projects coming along your way.
sir.
Yeah, if it helps, then certainly yes, worth a trial.
Yes.
Why,
And,
why not, sir? Why not? Why not, sir?
Yes, sir. So for we have done 5 patients, sir, and all the 5 had some financial support. Like one is from Atomic Power, so Atomic Power gave funds. Another is from Army guy, so the Army guy gave. Another is guy from Bhutan, so Bhutan the crowdfunding helped him to make some money. And Tuvalu guy, UN sponsored for that small boy the entire stay. So another guy is a neurosurgeon. Who met with an accident during a second year of residency. So, and he also got crowdfunded, and most of our neurologists and neurosurgeons contributed for his surgery.
So initially, yes, we can get funds, but how long does this need to be continued, Shankar? For how many years does it need to be continued? Is it going to be forever?
Sir, I have seen for 3 or 4 years follow-up from Switzerland. After 3-4 years, they don't need stimulation. The battery can be switched off and they will be able to walk. So the University of Lausanne is the one which started this procedure from the beginning. So now
Switzerland.
Switzerland, sir, Switzerland.
Yeah.
So 4 or 5 years down line, they don't need the stimulation. We can switch it off.
That means can we remove the electrodes then?
Not necessary, sir. There comes the trouble. It adheres to it. And our MIN did this procedure long before. So-
TENS, Professor Kanaka used to do
Yes,
transcutaneous electrical stimulation, nerve stimulation.
yes,
Yeah,
yes.
that I know, of course.
In our
it is done.
history,
But
yes,
but comparatively, that comes nowhere near this. That was done more for pain relief
yes, yes,
and
yes,
to reduce the spasticity.
yes. So spasticity, pain are all like proven, and autonomic, it is proven. Even in Parkinson, with refractory orthostatic hypotension, now epidural is going to come as a modality of treatment. Even freezing of gait, all those things, epidural electrical stimulation will be a boon in the near future. So it is not only for paraplegia, it will come into movement disorder also.
So it has to
Thank you,
be-
Shankar. Thank you
Thank you, sir.
for that.
Can
Again,
it-
illuminative explanation of the procedure. Yes.
Can it be done for cervical cord disease?
Cervical, yes, sir. Cervical, I have not done cervical, but I have seen cervical cases. They will be able to take a cup of water to the mouth. So the upper motor functions are completely more fine-tuned. So writing is not, you find it difficult to bring writing movements, but feeding is one we usually target. And when we put a chip here, but lower limb, we couldn't get much when you stimulate the cord. But wheelchair bound taking food to the mouth is possible for the cervical. And very good, cervical is more associated with autonomic disturbances. So that will get.
You did mention that it is good for bladder disturbance also, isn't it?
Yes, sir. Bladder. and-
Isolated, sometimes the myelopathy improves, bladder continues for a long period of time. So in that sense,
Yes, yes, especially this will be useful for multiple sclerosis, NMO, MOG, patients who got a scar tissue, but still if you want to bring a bladder control in them, then this method can holds good. But when it comes to only bladder and bowel, sacral neuromodulation is more appropriate, sir, more appropriate. Sacral, because it gives a trial. So when you put it's done in the cath lab. I put the electrode close to the sacral nerve through the foramen, and we stimulate it to look for the pelvic bellowing phenomenon. The pelvic muscles contracts, and we keep the patient for 7 days. We do the program, and we achieve if we achieve 50% improvement in the bladder symptom, then the trial is considered positive, and we can put the implant with the help of a surgeon. So sacral stimulation, also it is only bladder and bowel, rather than going for epidural electrical. Simple sacral modulation itself we can achieve what we want.
I think you would have come across Dr. Ram Narayan, neurosurgeon, who has been talking about these procedures, various procedures, and that he says he does those procedures.
Yes, sir.
Have you seen some of those patients?
I've done one redo surgery of his patient, deep brain stimulation. So electrode was not in the target, and patient had a lot of psychological manifestations, and he become like a schizophrenia. So once we redo it, he completely, everything was, even the behavior, everything was back to normal.
Continue, Panama.
Yeah. So what I would recommend is all these neuromodulation procedures. It's a new area to explore. Ethical is more important rather than exciting. So go steady and slow would be ideal, sir.
Thank you.
Any other questions from the participants? I think there is no question. So if there is no question, we can move on to the next case. Thank you, Dr. Balakrishnan. Thank you, Shankar.
Thank you, sir.
Thank you, Shankar.
Thank you, sir.
Entirely new information for us, both the cases as well as this procedure. Thank you, Mr. Shankar.
Thank you, sir.
Thank you, Shankar. So we can move on to the next case. Dr. Aruna from SRM.
Good morning, everybody. I am Dr. Arunan. There is a small change in the case. I have informed the VNSR also. This is a different case that was not mentioned in that. This is a peripheral nervous system case. And we will have some discussion after the case. I request Aruna to share the screen and go on.
Is it audible? Good morning, sir. Good morning. Good morning, sir. This is Dr. Aruna, resident doctor, first year, SRM Medical College, Chennai, neurology. Welcome. It's audible, sir?
Audible.
Audible, but you'll have to widen your screen.
Make it full screen.
Full screen.
Make it slideshow, Aruna.
Yes, sir. Okay, sir. This is a case of neurorheumatology disorder, sir. And 35 years old female by name Revati, an occupation housewife residing at Chengalpattu, came to the hospital with chief complaint of numbness of both hands and feet since 5 months and weakness of both hands and feet since 3 months. And the history of present illness, she was apparently normal 5 months ago. After she developed swelling involving both her feet, which subsided after treatment at a hospital nearby. 2 days later in the morning, she noticed pulling sensation below her ankles, followed by numbness both feet and hands simultaneously. Numbness gradually progressed in a 2 months' time. She could not perceive the ground, could not perceive pain in her extremities. History of cotton wool feel of ground was present. While bathing, she noticed not able to differentiate between hot and cold water in her hands and feet. History of burning, spontaneous pain, pins and needle sensation is present. And she had severe unsteadiness on attempting to walk, sir. On attempting to stand also, she had unsteadiness of walk, which was worsened in the and an eye closure was present. She also had difficulty in gripping slippers and unaware slippage of slippers, that it is present. 1 month after the initial symptom, she noticed slapping while walking her feet due to her forefoot hitting the ground. No history of buckling of knees. She had difficulty in getting up from squatting position. She could not mix the food or eat due to spillage of food between her fingers, and thinning of muscles of hands and feet is also present. And no history of difficulty of rising of arms above the shoulder. No history of stiffness or plainness of limbs. No history of facial weakness. No history pertaining to cranial nerve involvement, cerebellum, and autonomic system. No history of altered behavior, loss of consciousness, and seizures. No history of fever, headache, and photophobia. No preceding respiratory infections and diarrhea. No history of joint pain, rash, loss of weight or appetite, and no history of oral ulcers. No history of trauma and no history of neck pain. No history of exposure to toxins and pesticides. And a past history of, she is a known case of hypertension since 5 months. Patient is on telmisartan 40 mg OD treatment. Not a known case of diabetes, seizures, bronchial asthma, tuberculosis, CKD, and coronary artery disease and chronic obstructive pulmonary disease. Personal history, she is a mixed diet, normal appetite is normal, normal sleep, normal bowel and bladder habits. Family history, no relevant family history. And menstrual history, her cycles are regular, 5/28, normal flow, no passage of clots and no dysmenorrhea. Obstetric history, she had 2 children, para 3 live 2 children. Last childbirth is 9 years ago. First child is IUD at 39 years of gestation, 39 weeks of gestation. And treatment history, patient had constipation. She took some Ayurvedic medication outside for 2 months. And drug history, patient on amlodipine and telmisartan 2.5 mg amlodipine, telmisartan 20 mg OD. Tubectomy done 9 years ago, no history of drug allergy. And summarize that a 35 years of female complaints of loss of pain, temperature, loss of sensory modalities, complaints of loss of sensory modalities, and decreased complaints of thinness of hands and feet, and decreased sensations of touch, pain, temperature, could not appreciate hot and cold water, maybe due to large fibers and small fibers is involved for this patient, and history of difficulty in starting the position, maybe involving because of proximal weakness secondary to neurogenic wasting, and loss of all modalities, large fiber and small fiber neuropathy, along with sensory ataxia, without autonomic involvement, without cranial nerve involvement, with normal higher mental functional abnormalities, no history of plainness and no stiffness of limbs, no relevant family history, only 1 IUD at her 39 weeks of gestation at her 25th year of age. This is the history, and probable structures are involved, maybe large fibers and small fibers.
Aruna, can you give more details about the Ayurvedic treatment she had? For how long? Is she still continuing? And what was the nature of the treatment?
No, sir. She will tell, sir. She has stopped. She took for a short time only, sir. It was not a very long time. Only for constipation she has taken, sir. Nothing else. Most of the details they didn't have. They said they took, because we have the habit of asking, we asked, and she said only for constipation she has taken.
When was it taken, sir?
Some
before
the onset of the illness only.
No,
sometime before.
How many days before the onset of?
Not exactly, they don't know, sir. It's sometime before only. Landrayan, you remember?
Yes, sir. So the patient had a habit of taking Ayurvedic medicine long before the onset of this neurological symptoms started, sir. So there is no temporal connection between the consumption of Ayurvedic medicines and the onset of the neurological symptoms. So she took some incidentally long before the onset of the neurological illness, sir.
Okay.
You can continue, Aruna.
Continue, Aruna.
Okay, sir. On examination, patient conscious, oriented, and her vitals and blood pressure is 150 by 70 mmHg, left hand, and pulse rate is 88 per minute, respiratory rate is 14 per minute, and higher mental functions are normal, memory is normal, mini mental score examination is 30 by 30. And this is a cranial nerves examination for this patient. All cranial nerves are normal. First cranial nerve is normal. Visual acuity is 6 by 6. Second cranial nerve. Field of vision is normal. Color vision, fundus examination, everything is normal. Direct light reflex and indirect light reflex is normal. And the third, fourth, sixth cranial nerves, pupils 3 mm reactive to light, both right side and left side. Extraocular movements is full. Seconds and pursuits, everything is normal. No nystagmus. And fifth cranial nerve, motor system normal, sensory is also normal. Seventh cranial nerve, no asymmetry. Eighth is Renes, air conduction is greater than bone conduction. Right and left mode is both are normal. Weber's is no lateralization. And ninth and 10th cranial nerves are normal. Uvula normal in position in midline. Palatal movements are normal. Gag reflex is normal. And 12th is also normal. In this patient, all the cranial nerves are normal, sir. And the motor system bulk is also normal in both right side and left side, upper limb and lower limb. Tone is also
No, what happened, Aruna?
abduction 4+ and adduction 4+. 4+, abduction, adduction, both are, abduction is 4+, adduction is 4. Knee flexion and extension, flexion is 4, extension is 4+. Ankle, dorsiflexion, inversion, eversion, everything is 0 for this patient. And reflexes are corneal and conjunctal reflexes are present, abdominal reflexes is present, plantar absent, ankle is also absent, biceps, triceps, supinator, knee jerk, everything is diminished. There is a wasting of hands and feet. Both hands and feet is involved. That is bilateral claw hand and bilateral foot drop is seen in this patient. And sensory system, pain, touch and temperature decreased bilaterally below wrist and ankles. Joint position and vibration decreased bilaterally in both metacarpophalangeal joints and distally decreased in bilaterally ankle and below. Autonomic nervous system, no tachycardia, no sweating, no tropic changes. Cerebellum is normal. Extrapyramidal system is normal. Gait, she should not walk by herself. Because she had, initially she had a problem of inability to squatting position, she had a problem because of the bilateral foot drop. This patient, she didn't, initially she didn't walk. Slowly walking patient after that treatment, physiotherapy, now still patient is walking with support. Rombox is positive. These structures are involved as LMN syndrome.
1 minute, was there any history of involuntary movements? And
No,
was
sir.
there any pain in the limbs?
Sir, no history of involuntary movements and pain in the extremities, sir. Feet and hands, she had pain.
Any fasciculations, twitching?
Nothing,
Myokymia.
sir. No, sir. No fasciculations, no twitchings, no myokymia. Only pain sensation in both hands and feet. And weakness of hands and feet.
And symptoms started in the hand first and then went to the legs, or both simultaneous?
Simultaneously, sir.
Okay.
And structures involved are lower motor neuron syndrome. Distal is greater than proximal of all 4 limbs. Glove and stocking paresthesias may be due to vasculitis. And provisional diagnosis are distal motor, sensory, axonal type of polyneuropathy. Sensory is more than motor. And mononeuritis multiplex as evidenced by bilateral claw hand and bilateral foot drop. Indicates involving bilateral ulnar nerve and bilateral common peroneal nerve.
There's no pain, no? Is
This
there
pain
any?
is there, sir, for this patient.
Initially pain was
Pins and
there.
needle sensation pain is there, sir, for this patient.
See, she has weakness of the adductors and she has weakness of the flexors of the knee, adductors of the hip.
Yes, sir.
And she also has sensory in both upper limbs and the lower limbs, which is not in a nerve pattern. I assume that it is not in a nerve distribution. Am I right?
No, sir. Below
The
hands and
sensory, no, the sensory involvement was below the ankle and below
hands
the
and
wrist.
feet. Yes, sir. Yes, sir.
So, no, the reason for my saying that is you are saying mononeuritis multiplex and saying ulnar nerve and common peroneal nerve is involved.
Yes,
But
sir, yes,
there
sir.
are more nerves involved than that. It is not
Yes, sir.
mononeuritis, it is a
Sir,
polyneuropathy.
it is more of polyneuropathy, sir.
Yeah,
rather
it is
than,
a polyneuropathy. That's what-
polyneuropathy. But
Both
the
diagnoses.
onset was like mononeuritis, sir. That's why she is telling like that. Onset was like mononeuropathy. Pain was there. Initially also pain was there.
So
Now
it's a
the
painful
presentation is not-
polyneuropathy.
Sir, yes, sir. It
Painful
is a
polyneuropathy,
Yes, sir.
distal
Yes,
more
sir.
than proximal.
Proximal.
Yes, sir.
And motor and sensory.
Motor and sensory.
Motor rather more than sensory.
Yes, sir. Motor more than sensory. That's why we have put motor first.
Correct, correct. Continue, Aruna, continue.
And these are the differential diagnoses for this patient. Connective tissue diseases like SLE and Sjogren syndrome and vasculitis, any immune mediated like polyarteritis nodosa and CID variants, paraneoplastic, and finally Hansen's disease. The DDs, differential diagnosis. for this
Total
patient.
duration, 7 months.
5 months, sir. 5 months history.
5 months, okay.
Mm.
And still progressing.
Yes, sir. Now, sir,
Was progressing, sir. Was progressing.
at the time is progressing, now itself patient is on steroid, that pain of pins and needle sensations is reduced, but motor weakness is not reduced, slowly improved. Maybe. Patient came for physiotherapy for weakness, the hands and feet. Only. But pins and needle sensations is reduced, that treatment.
CADP variant, that would be high up in the list.
Sir, we investigated, sir. We investigated.
That's right. No, I'm just saying, so far,
Yes, sir.
we are going by the presentation.
Yes, sir.
Probably CIDP variant of that should be high in the list. So,
Yes, sir. We
continue,
had it
continue.
in mind. We also ruled out Hansen also.
Mm.
And we did the investigation, sir. for,
let her continue.
all the-
Let her continue.
All the mentioned things, we did the investigation. The presentation is polyneuropathy only, sir. Motor sensory polyneuropathy, distal motor sensory polyneuropathy. And initial presentation progression, she couldn't come out exactly how it progressed. So it could be a mononeuritis multiplex at the onset also. We couldn't identify. But the current presentation is polyneuropathy. Go on with the investigation, Aruna. Go slow. You'll finish by 10 minutes, I think.
Okay. And complete blood picture, hemoglobin is 13 grams per deciliter, mean corpuscular volume 83 femtoliters, MCH is 20 picograms, MCHCC 33 grams per deciliter.
Intermittently, you go off, Aruna. Why? Net connection is not good. Hello?
C3, C4 is complement 3 and 4, is it?
Cubic millimeter and differential neutropils is 78.5% per liter. RA factor is 8.1 international units per milliliter. C3, C4 is low for this patient. Peripheral smear, no hemoparasites, normocytic, normochromic picture. RFT serum creatinine is 1 milligram per deciliter. Urea is 28 and uric acid is 3.9. Fasting blood sugar for this patient is 80 milligrams per deciliter. Postprandial is 146. HbA1c is 5.6. Sodium 135 milliequivalents per liter. Potassium is 3.5 milliequivalents per liter. Liver function test, bilirubin is 0.9. Protein is 6.7 gram per deciliter. Albumin is 4 grams per deciliter. Globulin is 3.0 gram per deciliter. SGOT 22 units per liter, SGPT is 20 units per liter, alkaline phosphatase is 72. Her viral markers is HIV, HBsAg, HCV. HBsAg, HCV is negative, HIV is non-reactive. And thyroid function test, free T3 and free T4, 2.03 and free T4 is 0.99, TSH is 2.70 milli-international units per milliliter. Vitamin D is 845 picograms per milliliter, folate is 11.63 nanograms per milliliter. Complete urine examination and color of the urine is pale yellow, appearance is clear, albumin is nil, sugar is nil, RBC not found, and pus cells is 122, epithelial cells is 122, no CAS, no bacteria. Ultrasound abdomen for this patient is normal study. CSF analysis also done to this patient, appearance is clear, opening pressure is 15 centimeters CSF, sugar is 86 milligram per deciliter, protein is 22.4 milligram per deciliter, cell count is 1 cell per 10 power 6 per liter, ADA levels is 10 international units per liter. As a dermatologist, we obtained opinion from dermatologists for split smear study that is negative for Mycobacterium leprae. And this is the NCS report for this patient, sir. That is axonal variant neuropathy. Left ulnar synapse is obtained and other synapse is absent. This is the ANA profile of this patient. Anti-nuclear antibodies is 1:100 dilution. Positive ANA. This is other profile, anti-double stranded DNA antibodies. That is, this patient is positive, anti-double stranded DNA antibodies. These are the other antibody test. ANA is positive and nucleosomes is positive for this patient. Histones is negative and remaining all parameters is negative. And this is the treatment for this patient. Mycophenolate mofetil 500 mg morning and evening, and Vicilon 40 mg morning, Envas 2.5 mg morning, and Maxgalin 75 mg night time, and Pantop 40 mg OD for this patient. Now the patient is on this treatment.
What was the initial treatment, acute treatment? Go to the previous slide. Was she given steroid? Was she not given
Yes,
steroid? Yes, you tell that.
Yes,
You are
yes,
saying
first the
correct.
patient is on steroid for 1 week, followed by after that investigations, we add this mycophenolate mofetil for this patient along with steroid. Initially, we gave steroids to this patient for 10 days. 7 to 10 days, patient took steroids. Vicilon 60 mg OD.
Change the slide, Aruna.
Okay, sir. These are the neuropsychiatric manifestations of SLE, central nervous system disorders, seizure disorders, cerebrovascular disease, headache, and movement disorders like chorea, myelopathy, demyelinating syndromes, aseptic meningitis, acute confusional state, and cognitive dysfunction. And peripheral nerve system polyneuropathies, acute inflammatory demyelinating polyneuropathies, autonomic disorders, mononeuropathy, single or multiplex, myasthenia gravis, cranial neuropathy, and plexopathy. Psychiatric is psychosis, mood disorder, depression, and anxiety disorders. And these
On
are
to the next, no need for that.
And these are the peripheral neuropathies of rheumatological diseases and gluten-related disorders. Here, SLE, multifocal neuropathy is 10% in SLE, distal sensory or sensory motor polyneuropathy, that is 55%, and small fiber neuropathy 15%, cranial neuropathy 10%. And remaining is 5%. Connective tissue diseases and associated neuropathies, that is rheumatoid arthritis, mostly compressive neuropathy, SLE, polyneuropathy, and polyarthritis nodosa, subacute chronic mononeuritis multiplex, and Sjogren syndrome, symmetric distal sensory neuropathy, autonomic neuropathy, trigeminal neuropathy. Thank you.
Are you labeling
Madam,
this as lupus or what's the point to say there is a lupus?
Yes, sir.
dsDNA is negative, no?
dsDNA positive, sir, for this patient.
Positive.
Antibodies is positive for this patient.
Okay.
Nerve conduction studies are done.
Madam, what are the other systems?
Aruna, can you show the nerve conduction studies again?
Yeah,
Can
you
you show
come
the
to the
values, please?
Previous.
Okay.
Nerve
Okay.
conduction study. You went on fast.
Correct.
Previous.
This one, sir. NCS report for this patient.
Axonopathic changes only.
You mean none of the lower limb nerves were stimulatable? Am I right?
Yes, sir.
Yes, sir.
Both motor and
Only
sensory.
left ulnar nerve, sir. Other not stimulated.
Surale kanume madla.
No, and even
Lower limb nerve not stimulatable, sir. Only
All
left ulnar nerve snaps obtained. Other.
both ulnar snaps obtained. Median, not median.
What were the other organ systems involved?
Actually, she had nothing else, sir. We evaluated. She had nothing else.
Arna, why is it not a CIDP variant of DS?
This patient CADP variant, sir. That
Distal acquired demyelinating motor sensory neuropathy.
Sir, we did the CSF also, sir. CSF proteins
CSF
was
is
positive.
CSF need not. CSF may be normal. Yes, of course.
But the other things are positive, sir. Then
What does it? Does your rheumatologist concur with the positivity? Does he give significance to that?
yes,
Because
sir.
1 in
he gave,
100, we see that several times.
yes, sir. He gave. We got his opinion also, sir. He was not very comfortable that it is definitely SLE. He said it's
Correct.
okay, you can take it because the other symptoms are not there. But we referred, sir, so many times. The SLE, the first presentation could be a peripheral nerve involvement, sir.
Yeah, I know Arnan is very fond of that. You
Yes, sir.
even presented
Sir.
a case, or I think.
Sir, you
published a
remember
case.
our case, sir?
Yes, I do
when I was
remember,
in first
Arnan. I
year.
do remember.
That Muslim
Sir.
lady, sir.
Sir, only
I do
one
remember,
interjection.
Arnan.
Hello, sir.
Hello?
Yes.
Tell me.
Can we
Again,
call this
come on.
non-systemic? Can we call this just non-systemic vasculitic neuropathy?
Non-systemic vasculitic neuropathy. If you want, we can call it, sir.
You
We
mean
have to
isolated peripheral nervous system involvement?
Yes, sir. Non-systemic vasculitic neuropathy, because other organ systems are not involved at all. So
Yeah,
instead
that is
of
what I
labeling
think
it,
Arnan is saying.
instead of
instead of
labeling it
saying-
as SLE,
Instead of SLE,
call it,
you are not giving the label of SLE.
Yes, sir.
SLE,
100% you
right.
cannot give, sir. That's what rheumatologist also said.
so we
We
can call
discussed
it
with you.
non-systemic vasculitic neuropathy.
Possible, sir. Non-systemic.
But what is there for a vasculitis unless you do a biopsy and show that
Biopsy,
there
yes,
is vasculitis?
yes.
Patient was not ready, sir, and she has started improving also. Actually,
Correct. Yes.
and our patients are very much agitative against this surgery.
Agreed.
Yes, sir, yes, sir.
What
I
I'm
think we
saying
can
is
label it
to
as
say it is
non-
vasculitis, you need to
We
have
need surgery. Need a
biopsy.
Biopsy.
So we can call it non-systemic vasculitic rather than SLE.
SLE,
That
yes.
would be a better label than
Exactly.
calling it SLE, because she has responded to
But
immune
still, the
modulatory
CIDP
therapy.
variant holds good, sir. Yes, sir.
Sir?
Sir, sorry.
See, you ask CIDP variant, how can you rule it out? Still, it is valid, sir. Now,
DADS is still valid, no?
still valid, sir.
Yes.
Considering the investigations,
Nerve conduction study is
the
not supporting that.
The
nerve connection.
The nerve
the nerve
conduction is more of
okay. Nerve conduction, if we take it, most of the nerves are not excitable. I agree that the amplitude is down in the upper limb nerves.
Yes, sir.
But that is the only thing which probably, and the distal latency is not prolonged.
Sir.
But what happened to the F waves in those where we could acquire a CMAP? What was the F waves in the upper limbs?
F saves are not not obtained, it seems, sir. Only
Ah.
left median latency is mildly prolonged, sir. So the upper limit.
No,
is-
even there, she has not given any values for the F minimal latencies. She has not given any values.
I would not have got the F, sir. That is the possibility.
Left to median, there is a F value, sir.
Ah,
Left to median.
median.
இல்லையா?
இருக்கு சார்.
அது 55 இருக்கு சார்.
அது வந்து nerve conduction velocity போட்டுருக்காங்க.
ஆமா velocity F இல்ல. F எதுலயுமே
F
இல்ல.
கொடுக்கல, F இல்ல.
இல்ல F வரல சார் எதுலயுமே, அதான் reason.
So even where a nerve was excitable, F waves are absent.
Yes sir.
Probably.
Even in excitable nerves.
Yes. So
Sir, root involvement, sir.
it is equivocal for as often it is equivocal for demyelinating and axonal
Axonal, yes,
involvement.
sir. Late demyelinating.
The distal demyelination always mimics axonal. There is a distal demyelination, it will mimic axonal only. So
Agreed.
I don't think we need to we have split too much on that. Agreed that definitely it is autoimmune, and agreed that definitely there are nerves involved. Agreed that definitely probably roots are also involved. So non-systemic polyradiculoneuropathy.
Yes, sir. That is possible.
Even Vijayan,
Sir,
the only amplitude which is given proximally is for the left median.
yes sir, yes sir.
And if you see that, there seems to be at least, I mean, by the values, there seems to be a conduction block. It is only not even 1/4, it is 1/6. So fall
Agreed,
is
sir.
so great.
Yes, sir, yes, sir.
But
Yeah.
agreed, sir, agreed. So again, that can occur with vasculitic also.
Yeah.
Focal.
The question was whether there is evidence of demyelination. There is evidence of conduction block.
Yes. In only one one yes.
That's the only value given.
Yes.
That's the only value given. You don't
Yes, sir,
have
yes, sir.
values of proximal amplitude elsewhere.
That's the only
Agreed, sir,
value
agreed.
got,
A
sir.
biopsy would have definitely helped this patient. Definitely, a biopsy would have helped us to give a label to this patient. But,
Yeah, but
okay.
ultimately it's the treatment is the
Treatment-wise, it
same,
is the
and she has improved with steroids and immunosuppressants.
So definitely, treatment-wise, it's the same. It's going to be the same.
Correct.
So even claw hand and all have improved, sir. The last visit. She has improved very well. Some months only we have treated.
Non-systemic vasculitic neuropathy is coming in a big way.
Vasculitic polyneuropathy, Vijayan.
Yes, sir. Non-systemic vasculitic polyneuropathy is coming back in a big way. I remember I presented as a postgraduate. I presented non-systemic vasculitic neuropathy in Madurai Indian Academy of Neurology conference, and there we demonstrated with biopsies, but we didn't have any of this positive ANA and all. Nothing was positive except for
And the
raised
clinical
PSR.
features, Vijayan?
Clinical features mononeuritis multiplex, sir. Typical mononeuritis
So
multiplex.
that would have been a mononeuritis multiplex pattern, but here it
Yes,
is
sir.
not so. Here it is, that's the major thing. Here it's not
Yes,
a
sir.
mononeuritis multiplex pattern.
But I thought sir told that Arun sir told that it started off in one limb and then I think went on. So
See,
initial pattern was-
ultimately she has claw hand and she has foot drop, and
Yes.
she has a sensory nerve involvement of all nerves,
yes sir,
and she has proximal involvement also.
yes
The
sir. Yes.
adductors are
Agreed.
weak
Lower
and
limb,
the
yes.
flexors of the knee are weak.
So roots are also involved. Yes, okay sir, agreed sir. Even in prolonged critical care illness neuropathy, one should keep in mind the non-systemic vasculitic neuropathy. They do respond to immunomodulatory therapy.
Yeah, certainly.
That's a very nice case.
Thank you, sir.
Yes, Arun, thank you.
Yes, sir. It was Balaji's case that came to us. Sir.
Oh.
It initially seen by Chengalpattu Medical College. Sir. First report was like that from Chengalpattu Medical College.
Yeah.
Thank you, sir. Thank you.
Thank you, thank you.
Good morning,
Is
sir.
Shankar still there? Shankar, are you there?
Yes, sir. There is a question from Dr. Madan. Madan, yes, sir.
Sir, good morning, sir. Basically, I'm a neurosurgeon, sir. Few days back, I encountered one patient with hand and glove type of numbness, sir. Typically like diabetic glove and stock type of anesthesia, not complete anesthesia, decreased sensation, sir. The sensation was decreased for touch, pain, and temperature. The vibration sense was intact. No radiculopathy, no features of radiculopathy. But patient gives a history of COVID vaccination 5 months back. After that, she has developed this numbness. Is it possible, sir, as a post-vaccinal syndrome, such motor is completely normal, sir? No weakness or no wasting of thenar or hypothenar remnants, and those system motor is completely normal, sir. Only sensory involvement is there. Is it possible in post-vaccinal? Any possibility there?
What was the reflexes like, Madan? The deep tendon reflexes?
Reflexes were intact, sir, just present, sir. Reflexes were present, sir.
What is that interval between vaccination and sensory symptoms?
Sir, 5 months back, she had received the vaccination. After vaccination, 2 weeks after vaccination, she has gradually developed these symptoms.
I think it is very much possible. I think
dose or
she said second dose, sir. Second dose. After first dose, she was okay.
then it is very much possible. I
arterial
think.
involvements have happened, I have seen. And very pure symptomatic alone, I have seen. This type of symptoms. You said even examination shows something.
Madan, what was the examination findings? Was there sensory deficit?
Sir, sensory touch, pain, and temperature were involved in the hand and glove pattern, sir.
Yeah.
Only below wrist and below ankle it was involved, sir. She was able to perceive the vibration sense. Vibration sense and joint position sense was intact, sir.
Definitely, there is a temporal association. Whether there is a causal association, we'll have to prove it. That's all.
Okay.
To do other investigations, including a biopsy, of course.
Okay.
Mild involvement, Vijayan. Why do you want a biopsy?
Sir,
It's only sensory and that too a mild sensory involvement.
sir,
Some exaggeration of
We can observe and see, and that too we know it is probably post-vaccinal.
only to
in which
prove
case
it, sir.
should recover.
Only to prove it that it is not due to anything else. Only to prove that it is not due to anything else.
What would you get on that biopsy? What do you expect to get?
Sir, at least negative. It may be of negative predictive value at least. It may at least help us to say rule out toxins, other causes for a neuropathy. Then if everything is there, if there is a hyperimmune syndrome, COVID antibodies are elevated, maybe he can report this case also. Why not?
Oh, okay, sir. Okay, sir. I will further evaluate, sir.
We have had cases where there was myositis post-COVID, hyperimmune syndrome, myositis, including the involvement of brachial plexus and nerves, proved by MRI. Of course, cause a temporal association. Causal association, however, in these cases, I don't think it is very difficult. It's very easy to prove, apart from ruling out the other causes.
Yes,
Sensory nerve biopsy
radiculopathies,
can always be
myelopathies,
done.
all have happened following vaccination.
Yes, sir.
But once you do a conduction study, you will find more nerves to be involved.
Yes, sir. Correct. Yes, sir. Agreed, sir. We'll see more nerves involved in a conduction study. Yes, sir.
Okay, sir. I will perform nerve conduction study, sir, and proceed. Thank you, sir. Thank you very much.
Thank you. Thank you. Thank you.
Thank you very much.
Is Shankar still there? Shankar Balakrishnan, are you there?
Not there, sir.
I'm here, sir.
Here. He's there.
Yeah, I just wanted to ask you for that schistosomiasis,
Yes, sir.
prasequantal dose, is it the same as neurocystic or it's different?
If you are going to give the first dose will be 40 milligram per kg, sir. Otherwise, it's the same dose as of neurocystic.
But you continue for a longer period.
Yes, we continue for a longer period. First dose is 40, later on 2 milligram per kg per dose for 6 weeks.
Thank you. Velu, back to you.
Yes, sir. I think there is no question from, any other question from the participants? So if there is no question, I think we can conclude. I thank Dr. Aruna, Professor Arunan for the good presentation, and so we can conclude here. I thank Dr. Shankar as well as Dr. Aruna for the presentation.
Thank you, sir. Thank you so much.
Okay.
Thank you.
Thank you,
sir.
Professor Velusamy.
Thank you, sir.
Professor
I
Arunan.
felt like yesterday was the Tuesday, sir. I hope you understand.
Yes, sir. I understand.
Thank you, sir. Bye.
Thank you.
Thank you.
Thank you,
Thank you.
Aruna, and thank you, Shankar.
Thank you, sir. Thank you for the
Yeah,
opportunity.
those
sir.
were excellent
Thank you,
cases,
sir.
and the procedure also very good. Thank all of you.
Yeah.
And thank you, Ansari, for your
Sir, thank
cooperation.
you.
Thank you.
Thank
Thank
you,
all of
Yes,
you,
thank you.
sirs, and have a good day.
Thank you, sir.
Thank you, sir.
Thank you.
Thank you, sir.
Arunan and Velu, you are coming for IAM?
Yes, sir. Thursday night, Thursday night, I am coming.
No, sir, I'm not coming, sir.
Okay,
Sir,
okay.
you are not coming.
I'm not coming.
Sir, now varan.
Sir, you are going on Wednesday, sir?
Correct.
Yes, sir.
I am leaving on Wednesday.
Okay, sir. We'll see that.
Yes, sir.
Thank you, sir.
Your PGs are coming?
No, sir. PG not coming, sir. Only one PG. He
Oh,
won't come.
okay, okay.
Thank you.
Thank you.
Sir. Thank you.
Thank
you
all
very
of you. Thank you.
Thank you.
Bye.
Thank
Bye.
Thank you, sir.
Thank you, madam.
Thank you.
Thank you, Madan.
Thank you, sir. Thank you all. Thank
Yeah,
you.
thank you.